Hello, friends. Today we are going to talk about a very important topic, which is a systematic approach to a sick patient. And we will talk about initial assessment, primary survey, and secondary survey. Now, why does this topic come about? Is when I'll tell you a small story to begin with. Uh, During MBBS, we were always there was a fact that was told to us that you should before even you touch the patient you should be able to um, know about their illness by history itself. So you should first be able to take all the points in history and then examine and then intervene accordingly. But when I started working in emergency departments and started seeing very critically ill patients, um, I the first dilemma that I had was like sometimes they are just brought unconscious to the department, and I would be wondering what should I begin with. Should I take history, which I know very little? Sometimes there is almost no history at that point, and then should I examine or should I intervene first? Because sometimes if they have any difficulty like breathing difficulty or trouble in breathing or some acute bleeding, then there are you sometimes they'll be less than a minute or few seconds, so you have to act first. So this led me to um, think that there should be a systematic and a standardized approach to how any sick patient should be approached. And in this lecture, as we are talking about, by the end of the session, we will learn to identify an emergency based on patient appearance, develop a standard approach to manage emergencies using the ABCDE algorithm, which is a standard of all the life support courses that are taught, and learn components of secondary survey. Our theme is keep calm and be systematic. First thing, now having told you this, um, it is the when a patient comes to you. So say this patient comes to you, and they are probably lying on a stretcher or maybe they are standing. So you should be able to make an initial impression, and the question that you need to ask is, does the patient look sick? And if they look sick, how sick? And then, do they need urgent treatment? Now, how do you do this? If you look at this photo, I think we've taken this photo from some source in internet when we are searching for this word triage. This is, I think, this concept was first started in during World War II, when there may be many casualties, but essentially what you are looking at is and you had limited resources, so you had to identify um, you had to develop a system that the resources are spent on the people who are most ill and who would benefit from it the most. So saying that, let us begin with our next which is uh, bit, which is assessing the initial impression, which is often called as the 10-second assessment or doorway look. Like you should be able to understand if a patient is sick, how sick, and if they need acute treatment, immediate treatment based on a look. So when it comes to adults, so the as any person who is talking, so it is important to understand that if a person is talking, their airway is patent. That means the passage of air from outside from their mouth to lungs is adequate. If they are able to speak a sentence in a single breath, or they seem to be talking okay, that means the breathing is adequate. Their circulation, if they are walking and talking and answering your question, which is like just ask their name and what happened. uh, just asking this, and if they are able to answer your question, means that their brain is getting adequate amount of blood mixed with this oxygen, and this then you talk about something called as D, which is if you want to think what is disability, to check whether their brain or their nervous system as of now is working fine. So if they are talking to you fine, that there is no severe or major disability like which could happen in stroke, seizure, or hypoglycemia is not happening. So as simple as that, as soon as the patient come, see whether they are walking or talking, or they are only on a stretcher, whatever it is, just immediately first thing ask their name and what happened. If they answer, you know that they are, and they are answering okay, fine. But if not, then understand that there could be an immediate compromise in airway, their breathing, their circulation, or disability they may be having, and that means it could be an urgent emergency. So simply by talking you can understand that. But in children, they will not answer your question, and they may not they may be crying or things like that. So what do you do? So there is something known as the I think now the terminology has changed, but pediatric assessment triangle, where we are again looking at ABCs. So if you look at these ABCs, so you look at the child, imagine a normal, healthy, happy child. What would they look like? So they would be looking happy, maybe they're interacting, playing around, and uh, so that is their appearance there. You wouldn't, if a child is happy and comfortable, you won't necessarily even notice their breathing, and their would color would be looking like pink and nice. However, if you look at their appearance, then if you feel that they are floppy, they're drowsy, so you consider these things like their tone, interactiveness. If they're drowsy, if they are crying inconsolably, like just crying, how are they looking at people or looking at things around them? So all these things come under appearance. You look at their work of breathing. So as I said, a normal child would be breathing fine, and that wouldn't make any uh, you won't even notice. But if you are able to notice, because their breathing is noisy, they are you feel that there is increased work of breathing, which is because that you would be able to see that when they are drawing in air, you would see retractions, or their that they are sucking in air, and so, or the breathing would be very fast, so noisy fast breathing, or appears that they are drawing in air with great effort. So these are in the breathing aspect. And color of the skin, as I said, a pink, well perfused child, but otherwise it could appear like the child is looking pale, or their skin may be mottled or cyanosed. So hence, so this is where we talk about the initial impression and the 10-second assessment and the doorway look. So how to assess quickly in a person whether there is an immediate emergency, and in children just look at their appearance, the breathing, and the circulation and the color of the skin. Now, based on this, we usually triage. Now, this triaging is often done in emergency departments, where if you prioritize in the emergency department, you can put them in this sort of a triad scale, where you identify whether somebody needs immediate resuscitation. So this, or so they would like, they immediately need to be taken to a as a resuscitation bay or a crash bed, and treatment needs to start immediately. Whereas then otherwise you could classify them as very urgent, urgent, standard, and non-urgent. Now, so in meaning that this is how you identify that in how much time they should be seen, or otherwise the clinical condition may deteriorate. Now, this there's something that you may know that sometimes in disasters there is a tool that is used, which is simple triage and rapid assessment. Now, looking here, it is also based on all the principles that we have understood of airway, breathing, and circulation, and to understand because again, say imagine you are walking through where there has been a big disaster and you need to immediately identify the people that need immediate resuscitation. So first you can just ask, say, all the walking wounded um to um if they can go. So imagine there are 50 people in at a place where a disaster has occurred, an explosion or something like that. So you ask all the people who can walk to just walk 50 meters or 100 meters away from that place. So treat them as minors. But then the people who were not able to move from that place, that means there is a problem. So you first look at the breathing. So if they are breathing, so if first we look at this, if no, then you go about positioning their airway. We will talk about that later, but basically checking that their airway is in a neutral position. Um, you may perform head tilt or chin lift maneuvers, ensuring that there is no their tongue is not falling or not obstructing, and just basically see if still they are no respiration. You call them as they are considered as disease, but understand this is a situation only in a disaster situation where you don't have much resources. If they start breathing, once you had to position their airway, consider them as immediate. Now, they suppose they were already breathing, but if their breathing was very fast, over 30 per minute, like, so means problem, mark them as immediate. But understand the overall fundamental that now suppose now their breathing seems to be okay, like, so now you look at the perfusion, which is how their blood circulation is going on. So you would check it is like check the radial pulse, and if radial pulse is absent, so then means their uh, blood circulation is compromised. So you can check their capillary refill. In that case, capillary refill we will talk about later. How you check, basically this pressing on a person's thumb and seeing how soon the color comes back and gives you an idea of their capillary refill, like this. So yeah, you could check that, and if there is any bleeding that you notice, so if the capillary refill is over 2 seconds, find any bleeding and then mark them as immediate. Controlling bleeding is important here. If the radial pulse is absent but the capillary refill is under 2 seconds, or the radial pulse is present, so then we come to the disability part, which is mental status. Are they able to follow commands? So yes, so then that means they may be wounded but they can still follow commands. So there is their airway, breathing, circulation, and there is no problem in ABCD. So you mark them as people who can be seen as delayed, but if they are not following commands, means there is a problem in their D. So again, this is a simple flow chart, but helps to identify that any person, based on the simple principles of identifying person uh, an immediate emergency by simply assessing their ABCDs. So having said that, now we will move on to if we once we have identified that, based on all that we have checked until now, so we have talked about the initial impression, and so we have understood how to prioritize patients and identify an emergency based on an initial impression. And once we have identified that the person is unstable and needs immediate treatment, we move on to the primary survey. Right. So now we will move on to primary survey. So consider this, the overall systematic approach to be an outward to in approach. So first of all, as you've identified it's an emergency by just looking at a person from distance. So once you've done that, now you come on to primary survey, where now what you need to do is resuscitation. So your priority is resuscitation, or and treating quickly, identifying what is wrong with the patient. So you identify and you intervene and you evaluate. And for this, we will be going on to our ABCDE approach. Now, ABCDE, as we've learned, always it's not A for apple or B for ball, C for cat, D for dog, or E for elephant, but rather stands for A for airway, B for breathing, C for circulation, D for disability, and E for exposure. So this is how you start approaching a patient. So if, say, I have my patient here, so this is how we will proceed on to it. So as soon as you've identified it's an emergency, first of all, call for help. Now that could be a cardiac arrest call, could be an emergency call, a trauma call, whatever the call is. So you need to start building a team. Then you connect patient to the monitor and ask team members to record vitals. And out of all the vitals, you read here the saturation probe should be attached first. This, if a person who's even looking pale or looking or who's unconscious or who's having difficulty breathing, the oxygen levels should be assessed. So it is quite easy to attach. So this should be attached first, and then you control any exsanguinating bleed if present, which is by applying direct pressure. So these are your immediate priorities, and then you start assessing the patient in order of A, B, C, D, which we have mentioned here. So coming to airway. Now airway, like in my patient, I start assessing his airway. What do I do? Talk to the patient. If able to speak, then airway is patent. If drowsy or unconscious, so you check and open the mouth, check for secretions, foreign body, or tongue falling back. These are the most common causes of airway compromise in someone who is unconscious. Now airway is basically, as you consider this word, airway is air, way of the air. So from going on to your mouth, to the passage of the air to from your mouth and nose to the lungs is considered to be airway. Now sometimes when we are anticipating a difficult airway means that their airway is easily occluded, and you may, if you have to intervene, say for an intubation later on, there could be problems. So you say, if they are obese, have a short neck, limited mouth opening, then you should call for senior help early. Now what is this happening here? This animation is called the head tilt chin lift airway. So for someone who is drowsy, so what can happen is, now not in the cases of trauma, but if somebody is just unconscious and lying like this, just tilting their head and lifting their chin will help in moving the jaw a little forward and prevents the tongue from falling back. So this is what I was talking about. So you see the tongue. Now by doing this maneuver, this can be done. Now, first of all, now as if you identified as you progress onto the airway, so if you have identified that is there a problem, so you first of all do the basic things. So use a suction. You can use a Yonkor suction tube. You can, and then position. Now positioning, sometimes you can, if they are vomiting or if they have secretions, you can put them in side position so that all the secretions they flow off. You can do a head tilt chin lift as I showed earlier, and you can do a jaw thrust maneuver, which is more useful for should be done in patients who, in which we are considering, say, a neck injury in trauma victims. So because then you cannot move their neck and you can just only move their jaw a little forward to ensure that there is that you can relieve the airway obstruction. Now, these are the basic airway maneuvers, but then you move on to the basic airway equipment. What are the basic airway equipment? You can use OPA, NPA, or these are also called the supraglottic devices. So you can use oral pharyngeal airway, nasopharyngeal airway, and a laryngeal mask airway. Now, if patient is drowsy and they are having inadequate breathing, so in these cases you consider advanced airway. And uh, this, since we are just talking overall, we'll have a separate lecture on airway. So in these cases where we will talk about when to exactly and how to intubate and things like that, this is just like first basic airway maneuvers, then you consider basic airway equipment. If a patient is drowsy as well as not breathing inadequate, then we will put advanced airway, which is basically something like this endotracheal tube here, which goes beyond the level of vocal cords, so which we call as a definitive airway. Now, endotracheal tube size 7 to 7.5 in adult females, 8 to 8.5 in males. You should keep laryngoscope and the drugs ready for RSI, which is rapid sequence intubation. So this is just an overview of this. In children, the size of laryngeal tube would be age by 4 plus 4. So that's how we go about it. Now, breathing. Now, as you move on to assess, once you have secured the airway, whatever you had to do with have you relieved it if you've identified an airway obstruction, and then you identified and you intervened by either a basic intervention or or an advanced intervention. Only once you have sorted out airway, and then you move on to breathing. Now, most important things to check in breathing is saturations and respiratory rate. You check at there. Now this is all assessment going on. So you look, how do you assess? You assess the breathing pattern, nasal flaring, use of neck muscles, subcostal retractions, increased effort of breathing or increased work of breathing. You can look for uh, uh, check for the air entry, check for any unusual sounds like crepitations or wheeze, and consider chest x-ray, blood gas, ABG, arterial blood gas, or just a venous blood gas in most cases, and lung ultrasound can be of help. Now, as you look at this, the breathing interventions, now you've felt that the saturation was low, so you, first thing, whenever you have to support breathing, you connect them to oxygen. You can use a nasal cannula or you can use breathing or non-breathing masks. Now, what are the problems that can happen? Now, in primary survey, we are only looking at the compromising or emergency situations which need immediate intervention. So such a thing can be tension pneumothorax, where it is the air, for some reasons, like somebody, if they have a penetrating chest trauma, so there can be air trap between their lung and the chest wall, which can cause the lung to squish away or like collapse. And a tension pneumothorax, then the air in that side builds up so much that it starts shifting or pressing on the blood vessels coming to the heart also. Person can go into shock in these cases. If you would see their breathing, air entry absent or different in both sides, and limited chest movement, and the note would be resonant. So these things going on, you do these you will need to do a needle decompression, but you could straight away do a thoracostomy by putting in an intercostal drain, which is usually done in the fifth intercostal space anterior to the mid axillary line. Now, if you see that the person is tachypneic, means breathing fast and there is increased work of breathing. So, if they are alert, you can consider non-invasive ventilation methods such as CPAP or BiPAP, which is continuous positive airway pressure, or bilevel positive airway pressure. Of course, if they become drowsy also, then advanced airway with ventilator support is to be considered. Now, we will go on to the specifics of this as we move along. So once you've sorted out the breathing, so now you've gone on to airway, breathing sorted, but the person may be in shock, which is now coming to the circulation assessment. So signs of shock would be acutely altered mental status, low blood pressure, chest discomfort, shortness of breath. So these are all signs that there is the person's overall heart pumping capacity to blood reaching to all the parts of the body. There is some compromise in that. So the circulation is affected. What do you need to check in circulation? You check for heart rate. You check the heart rate, the rate and rhythm. You check the blood pressure, systolic blood pressure, diastolic blood pressure, and mean arterial pressure. And you check for the capillary refill time. You could, if you are you have ultrasound, you could do something called as the rush protocol, which is rapid ultrasound in shock, and prepare IV access and connect to defibrillator. So, or defibrillator, basically your your cardio for cardioversion. So this is how you would imagine the circulation going on in your body. So blood coming into the heart, left chamber, into the aorta, into the body where it converts, gives off oxygen. This deoxygenated blood comes into the right side of the heart, into the pulmonary artery, gets oxygenated and comes back. So understanding of this circuit is very important. So if this is quite important to understand, and because this is how for your body to stay, for a person to remain alive, this bit of circulation between the heart and the lungs and the brain, this bit is absolutely important. Of course, the remaining organs are also critically important, but this is most essential, this bit, and then it comes to the remaining parts. So you assess if there is any signs of shock. You check for circulatory compromise. You check their heart rate, blood pressure, and we talked about the capillary refill, where like pressing onto someone's finger, say this is blanching, and then I take it off and the color resumes, and it comes back in within 2 seconds. If it is more than that, there should be a problem. So what do? You prepare your IV access, connect the patient to to the monitor. Now shock. What is shock? A very brief explanation here is basically insufficient blood supply to tissues. But it does not mean that you always give just IV fluids for people in shock. you have to understand what is causing the shock. So shock could be of four types: the cardiogenic, obstructive, hypovolemic, and distributive, which is based on how your circulatory system is functioning. If there is a problem with the heart is not able to pump properly. That is why there is insufficient blood supply to tissues. So that could happen in ischemia, arrhythmias. So these are the things that you need to consider. Now, obstructive, so there is an obstruction in the blood flow, which can happen in pulmonary embolism, a cardiac tamponade, and tension pneumothorax. We've talked briefly about tension pneumothorax. Cardiac tamponade is when there is the pericardial sac surrounding the heart gets engorged with blood or fluid, which does not allow the heart to contract, so causing obstruction of blood flow. And pulmonary embolism, when if there is any blood clot formed in the deep venous systems of the heart, that of deep venous systems of the lower legs, usually that then go on to your pulmonary artery and causes obstruction. Hypovolemic, now this is usually the most common, where a person with say blood loss or dehydration may be having a hypovolemic shock. A distributive shock, where there is vasodilation in the system, such that the heart is pumping, blood is going, but it is because the blood vessels have become so dilated or porous that it is leaking from the pipes. It is your so it is there is leakage. Such a thing can happen in septic, anaphylactic, or neurogenic shock. So this is just a brief. We will probably have another detailed session on shock. So once you've identified that, okay, circulation, there is a problem, signs of shock, heart rate, blood pressure compromise, so what could you intervene? So if it is a cardiogenic shock, as I said, it could be ischemia, so you need to consider percutaneous primary intervention, such as to relieve the person goes to cath lab, thrombolysis when those cath lab facilities are not available. Now, if the heart is too fast or too slow, so it could be tachy or bradyarrhythmia. In tachyarrhythmia, you would need to consider things like cardioversion rate or rhythm control by giving medicines. And in bradyarrhythmia, you need to consider atropine or pacing. Now, if it is an obstructive shock, as I said, PE, you need to, because of a blood clot, you need to consider thrombolysis. Tension pneumothorax, we've already talked about decompression or intercostal thoracostomy. And in cardiac tamponade, either a pericardiocentesis or an open thoracotomy to be considered. Now, this is once you've identified what is the cause of the shock. This is a picture of a collapsed lung with a pneumothorax. Now, if it is a hypovolemic shock, what will you do? Of course, control any bleeding that has to be done. Instead of consider giving fluids and giving bloods, first thing should be to control any sort of bleeding. You will give warm crystalloids, saline or ringer lactate, Hartmann's you can give. You then would give blood products, whole blood, RBCs, platelets, FFPs. These are things to be considered if there's been bleeding. And if it is a case of trauma, then you also need to give your tranexamic acid, 1 gram IV bolus in 10 minutes. So what if it is a distributive shock? So like septic shock and things like that. So you would give fluids first, and if you say you've given 2 liter fluids and no response is coming, so you have to give vasopressors. So vasopressors here could be of so distributive shock we talked as so fluids. So you first give some fluids, but despite that, if the blood pressure is not coming up, then you give vasopressors such as noradrenaline or metraminol, and it also depends on the local practices, but these are commonly used. And then if it is a case of anaphylaxis, you will have to consider adrenaline, which is to be given IM if it's a sudden anaphylactic shock. And of course, if dealing further, if it is sepsis, you will also have to do correction. So you also need to consider start giving antibiotics. So now, coming to disability, we are still in a primary survey. So now, after we've sorted out A, B, C of the patient, we're coming to disability. Disability, so the things that we need to check out for is basically, is there anything acutely wrong going on with the patient, their brain, their central nervous system that needs correction and quick identification. But how do you check that? So first of all, check response. So are they alert? Are they responding to vocal commands? Um, or are they responding to, this is not pupils, this is responding to pain, or they are unresponsive. So AVPU scale. And so basically, if once you tap on the shoulders, so our mister here, I first see if he's alert, standing fine. If he's not, then I ask him hello, hello, and he responds to, when I speak to him, then he responds. Or if he's needing some painful stimuli, so then I say he's respond, then P, and not, then unresponsive. So this is just all my assessment going on. Then I check the pupils. So pearl, which is pupils equal round reacting to light. Note any size difference and reactivity. So this is the AVPU scale appearing here. This is a good diagram. And then you can look at blood glucose, which is, if it is less than 60 milligram per deciliter, then that may cause symptoms. So this blood glucose can also be, so blood glucose less than 60 milligram per deciliter may cause symptoms. Or if we are checking in millimoles per liter, in those cases less usual values are 3.6 to 5.8 millimoles, where per liter is where body keeps. So less than 3 may start causing symptoms. So once you've identified this, and this is how you would check your pupils, if they are round, equal reacting, the glucometer. Yes. Now, so we have checked first of all on the AVPU, what is the response. We've checked the pupils, we have checked their blood sugar levels, and then we go on to this Glasgow Coma Scale. I will be keeping a separate section to check for this, but this is a very important that you should understand how to check and the Glasgow Coma Scale, and how to mention it to anyone if you're giving a handover of a patient. So it's 3 parameters: eye opening, verbal response, and motor response. So a normal person, their eye opening would be spontaneous, they would be orientated, and they would obey commands. So as person goes down in their sensorium, their drops. So their eye opening can also, like, in AVPU, so they may be closing their eye but then respond to sound. Then are they responding to, if not responding to sound, are they responding to pain? None. So the least score that can be 1, 1, 1. So that is the 3 is the least score, 15 is the maximum score. Verbal response, none, no verbal response, and no motor response. And so now we need to understand what is the 432. So if they are appearing confused, so they are speaking some sentences but they're not making but appear confused, then that would be 4. But if they are not even able to make a sentence but only speaking some words, some random words, then a score of 3. And if they're just making sound like that, not making any sense, then that could be 2. Motor response, obeying 6. If you apply any pressure or pain and they can localize, uh, their hand reaches out to that point, that is a localizing sign. A normal flexion, um, or the response of the body to withdraw from a painful stimulus is considered 4. An abnormal flexion, so these 3 and 2 are very characteristic responses, where 3 is considered abnormal flexion or a decorticate posture, which you are seeing here, which is because of upper midbrain damage. So decorticate posture is this, where a person, you see like a boxer's pugilistic attitude here, the ankles extended, and then if it is an abnormal extension, which is a very poor sign, where the person hands on giving a painful stimulus, as they are giving in the supraorbital region here, and you would see this. So, and no response is 1. So considered scoring would be done. Mild is impairment, mild disability is 13 to 15, moderate is 9 to 12, and severe is 3 to 8. And usually a person with inadequate breathing and having a Glasgow Coma score of less than 8, we tend to intubate. This is something that we'll discuss later. We will come to know. Now coming to exposure. So of course, in disability, what you need to manage is, blood sugar is something that needs to be corrected immediately. And if person has suffered a head injury, trauma, seizures, then depending on, you will have to adopt all the ensure that their ABCs are functioning fine, so that their um, uh, the brain continues to get perfused properly. And you will need to send off few blood tests, and maybe get a CT if as required, depending on the situation. But these are things that you will do. But in your primary survey, all you will do is check the blood sugar levels and do your assessment. Now coming to the exposure means now you have to check a person completely, that is there any injuries, scars, rashes, any deformities, any bleeding, those sort of thing that you have to check. If a rash is there, especially in children, for a meningitis rash, you need to check blanchable or non-blanchable. What you can see here is called as an empty glass test, where if you see that a person has a rash and you put a glass, so if it is a blanchable rash, it's considered um, uh, less concerning as compared to a rash which does not blanch, which could be a sign of septicemia, in worst cases DIC, or meningococcus meningitis. So consider need to check back. So in some cases, so a person in a trauma patient, stab injury victims and things like that, or bullet injury victims, we do log roll in very high specialized centers where CTs are available immediately. So sometimes, for convenience, it may be considered that this patient gets a CT first if they are stable enough to go there. But anyways, do log roll. Record temperature if they are having low temperature or high temperature. So if they are having low temperature, then you need to ensure that the room temperature is here, is supporting and helping them warm up. and if it is very high temperature, then you need to cool their body. And so you repeat primary survey until the patient is hemodynamically stable. So as we said, it is evaluation. So identify, evaluate, and intervene. So you do that for every A, B, C, D, E aspects, and ensure. So you remember your primary survey is to stabilize the patient. So once your patient is stabilized, you have ensured, okay, you have identified any life threatening aspects in A, B, C, D, E's, and you have stabilized it, then you proceed to the secondary survey. So as it is mentioned here, so our patient lying here, we will proceed. So what do we do? Proceed from head to toe in a systematic manner. You should go from head to toe, examine all orifices carefully, note any discharge. Uh, no foreign body should be missed. Any injuries should be examined properly. Make note of any tube, pipes, drains attached to the patient. All scars, swelling, deformities, rashes, or injuries should be documented. And palpate for, uh, like, if you do not know whether a part is injured, so you should note if there is any crepitus, especially in those areas, if a person is unconscious. Of course, otherwise, the patient, if they are conscious, they can tell if a body part is tender, like their hand or feet. So head to toe examination. This is just a brief overview of how you should, now going on to the secondary survey. So when you head, palpate carefully for any injuries. You go to the eyes, pupils, visual acuity, eye movements, pallor, icterus, um, ears, nose. Check any bleeding or discharge. Uh, Assess their hearing, their smell capabilities, mouth. Check for injuries, infections, dehydration. Assess. So because if you're doing it carefully and systematically, you can do this very swiftly. So teeth, tongue, facial symmetry. So facial symmetry mentioned, because if it is someone, say, having a stroke or something, then or then facial symmetry can be affected. Neck, midline tenderness, trachea, their jugular venous uh, pressure, or basically their jugular veins, any swelling in the neck. Come on to the chest now, inspect, palpate, auscultate. Um, Percussion in the emergency department, I've sometimes I not found it much useful though. So, but anyways, if you can do that. Abdomen, then check distended, soft or not, any focal tenderness, any localized tenderness, any bowel sounds, how do you hear, what's the girth, um, any injury signs there. Pelvis, check for stability, discharge from any orifices, pressure sores. Consider PR in as per the case requirement, PR per rectal examination. Limbs, check for pulses, the edema, capillary refill time, swelling, deformity, and the range of motion. And neurological, limb, power, tone, reflexes, dermatomes, and the gait. So this is how you would complete your assessment. Of course, in the secondary assessment, not all of these are applicable for all the patients, but if you have a system in your mind, you will not miss important things. Now, in we have heard there is this form of an history which is taught in life support courses. Sometimes it's called ample or sample. We've also extended a bit and we call it a samplex history. So, so now it, a very important point here that I told you initially in the beginning of this lecture, that during medical college we were taught that first you take the history, then you go on to the examination, and then you do the you intervene. Whereas um, now the history, and sometimes if you are dealing with a very critically unwell patient, you may first have to do, as you identify, then you do the primary survey, you will have to intervene there, and then you move on to more detailed examination in secondary survey, and then you get history. And Samplex history here gets you a quick overview, a quick way of taking the history. So signs, what you see; symptoms, what patient complains of; any allergies; M for medication patient is taking in emergency department. Should focus on antibiotics, antiplatelets, anticoagulants, basically blood pressure, and uh, medication taken for diabetes, and also Parkinson's medications if there are. um, Past history, whether any past hospital admissions, prolonged illness, surgery, similar episodes in the past, should be considered, pregnancy and all. Now, L is last meal, but we should also consider asking last stools, last urine, and last menstrual period. Events is basically what happened to how the patient came here, the event and the sequence leading to the current situation. What happened initially is to how he got to the hospital. For example, two patients collapsed. One got up on his own, then he came to the hospital by himself, whereas other person collapsed, was picked up by people and came here via ambulance. So there is much detail in the so of course the person who was collapsed, did not recover, and had to be brought in by ambulance would be more sicker than somebody who collapsed and got to hospital by himself. So events is important. And X, all the important aspects of occupation, what does the person do, the habits, whether they live alone, with family, what are their main concerns, if elderly, then activities of daily living, and baseline functionality, where their mobility and cognition should be asked for and considered. uh, History, when you are taking, suppose somebody complains of pain, you should think of Socrates, which is, if you make this way of taking a history, it would be quite helpful. So S is site, where the pain is. O, onset, whether it was sudden or it started off slowly and gradually build up. So onset, sudden or gradual. Character, I let the patient define the character of the pain, whether it is burning, sharp, dull, all these things they can define. Radiation, if the pain starts from somewhere and goes on to somewhere else. A is for associated symptoms. So if they had pain in their tummy, did they have any vomiting? So things like that. If they had chest pain, did they have any sweating? So associated symptoms. Then time duration, T is time, for how long has the pain been going on. E is exacerbating or relieving factors, what makes the pain worse or better. And last, severity, how would they define on a scale of 1 to 10? 10 worst ever, 1 minimal, or 0 none. So if this is quite helpful, the remembering this acronym. So this way you would be able to take a comprehensive history of the patient. So I want you to take home this message, which is that it is an outside in approach. As soon as you look at a person, you should make an initial impression and identify whether it's an emergency. Then you should move on to doing the primary survey to treat life threatening condition. Then you should move on to a secondary survey, a systematic head to toe approach to ensure no finding is left. So the take home message is identify quick, be systematic, and once you get into the practice of it, you'll be able to think ahead. So A, B, C, D, E, You would remember the sequence of evaluate, identify, and intervene. And this is how you should approach patients in sick patients, and especially if you're working in an emergency department. So remember this: we are what we repeatedly do. Excellence then is not an act but an habit. Thank you.